cone beam CT parameters, injection rates, spin rates. What do you guys typically do?
So we do power injection proximally. It is 2 for 22. It's a 5-second spin with a 6-second injection or 6-second X-ray delay.
Okay.
So it's 11 seconds total with a rate of 2 times 11, 22, 2 for 22. I do that from the low bar. I do it from a proximal left, proximal right. And then obviously when I get further out, I use forearm strength for no reflex control.
Okay, so we do 5-second spin, 8-second delay, so a total of 13 seconds. And I have a 3-2-1.5 rule. If I'm doing common hepatic, 3 for 39. If I'm doing a right lobar, 2 for 26. Okay. Left lobar, depending on the size, either 1 for 13 or 1.5 for 20. And then for segmental, usually 0.5 for 6 or 7.
And I think we're all aligned. Proximal cone beam CT is imperative to success.
I think so.
Yeah.
First.
Yeah. First step. After you get it, yeah.
It's for people that go hunting first, you wind up getting burned, and then all of a sudden, it takes so much time to come back and retrace your steps. If you do that proximal cone beam CT first, you wind up seeing everything the way that you need to see it. And so if you say you catheterized the wrong vessel or you were burned, you have a reference point to go back to. You got to do it first.
And sometimes you see other lesions that,
agreed,
because there is delay, and this happens to all of us, that the MR that was discussed in the tumor board is 2 months old. So by the time you get to see the patient on your table, that MR is 3 months old. I had a case 2 weeks ago that she had a very large tumor in the dome of the liver. We did a cone beam proximal, and then I realized there were 2 not tiny, 1.5, 2 centimeter lesions in the corner of segment 2 and 3. One was obscured by the heart motion on the MRI, and the other one was right next to the gastric wall. So none of them were visible on the MRI that was a month old. I had to bring her back to do the treatment for those as well. So those are the things that you're not going to see if you don't do the proximal.
100% agree. My protocol, I have Philips. I can't remember if I mentioned that earlier or not. So I actually have access to dual phase scans. So then I'm less worried about perfusional differences and changing my X-ray delay. So my standard, I try to get a base catheter out into the proper hepatic, and then I'll do 2 for 20. I have a 5-second X-ray delay, 5-second spin, and then that's my lobar. And then I take my lead off and I sit down at the station and I figure out where I'm going to go, and I spend 10 minutes doing it. And it always pays dividends for me. So I do that invariably, pick my spots. The one nuance for me is I will do a DSA at every location to inform my injection rate for the cone beam. I do that very commonly if I'm not going to hand inject, to your point.
Power injection DSA?
I'll do a low volume power injection DSA to inform my cone beam so I'm not getting a bunch of reflux and then I can get an
I think that's reasonable. Yeah. And I inject, so I work my way proximal to distal, right? So you start celiac, then you go common or proper, then you go lobar, then you go segmental, then you go subsegmental. I think you have to work, or even if it's an anterior posterior division on the right, you work your way proximal to distal, and you do DSAs at each step.
Sure.
Especially if you're going to be doing a lot of them, or you're going to be treating a patient 2 or 3 weeks later, and you're not going to remember where you were. It informs you for how you made it to the spot that you need to treat from.
Yeah. Well, and it's not uncommon for me in my practice. I don't know how you both feel, but in a complex lesion, large lesion, multiple rad segs, I could do 10 cone beams in a single mapping, and that's not, my techs like to make fun of me, but I don't know how you both. What's your average number of cone beams?
5 to 6.
5 to 6, yeah. Right? Very common, right?
4 to 5, something like that. 8 to 5, something like that.
Yeah. And
I have no qualms about it.
None.
To me, I do as many of them as I need. I don't, because it becomes easy to set up. As you said, we put the arm next to the patient. We are doing radial for the most part, but it doesn't matter whether it's radial or groin. As long as the arm is next to the patient, the setup is very easy. It's basically essentially similar to a DSA. It's just a little bit longer, but it's almost the same. Yeah.
Well, and your cone beam is, again, paramount to success, right? So I have a 90-90 arm positioner. I can leave the arms up and it's relatively comfortable for patients. I do some of my mappings out of general as well. I don't know if you're both using general anesthesia for mappings ever.
We do. So Osher we have some hospital policies. If you have sleep apnea, anesthesia has to be involved in care. And so so a lot of people have sleep apnea, especially when Popeye's poisoning is prevalent in your region. So a lot of people have sleep apnea. So if anesthesia has to be involved, I need breath holds. And so if we have to use general anesthesia, patients wind up needing needing to be intubated so that we can do breath holds.
Well, it's helpful, right? I mean, if they're moderately sedated and they can't follow instructions, you're going to get crappy code data.
Yeah.
Oh, see, I yell at patients. I'll yell, I sternal rub, I pinch toenails. We wake up.
Okay.
And so
This is a very important point that if you are using anesthesia, ask for GA. Don't do propofol because you're gonna become frustrated. The anesthesiologist is gonna become frustrated. Most importantly, you're gonna get garbage information that is not gonna be helpful for your treatment planning.
Yeah, my patients are either awake, minimally if at all,
Arousable.
yeah,
Yeah.
or GA, full paralysis. Sorry,
Yeah.
I totally agree with that.